I'm Dr. Richa Thakur. I'm a third-year Hem/Onc fellow at Zuckerberg School of Medicine at Northwell, Long Island. And prior to doing a Hem/Onc fellowship, I also did a palliative care fellowship. So I'm really excited to talk to you guys about pain, and especially with how it complicates cancer diagnosis and treatment, and just overall quality of life. And with me, I have a really amazing person that's going to also be part of this podcast. So I'd love to introduce you to Mengzi. Would you mind introducing yourself too?
I'm Megan Claire Chase, also known as Warrior Megzi in the cancer space, and super excited to be part of Oncology Data Advisors Editorial Board. And I'm also an 8-year invasive lobular breast cancer survivor. And something that I rarely get a chance to talk about is pain once you've entered the survivorship stage. And so Richa, I'm excited to get this conversation going.
Oh, absolutely. So I think one thing with cancer-related pain is it's so complicated. There's so many different ways patients can experience pain. There's clearly direct pain from the actual tumor pressing on something. There's pain from the radiation of the cancer, like if it's pressing on a nerve. There's also other aspects of distress that just aren't well tolerated too, meaning like existential pain. And then, of course, there's so many gray areas of who treats what with terms of pain, because a lot of our cancer survivors really struggle to have pain adequately controlled, because at least at most institutions, it's usually the oncologist and the palliativist that co-manage the pain. But then at some point, when the cancer is cured and they no longer are seeing their oncologist, oftentimes they're also not really seeing their palliativist as frequently as they used to with their treatments. And that creates a very difficult dilemma for patients and practitioners too. What's your experience been like with, especially with pain in general, but particularly in the survivorship phase?
Well, something that honestly I knew that there would be pain during the treatments. I knew there would be pain post surgery, on healing. But I think what's often not talked about is sometimes you may have to have additional surgeries even after you have entered the survivorship stage from issues stemming from your original, surgeries from your diagnosis. And that's what happened to me. I had a lot of additional surgeries after my original one, so to speak, because complications. I had some fat necrosis that had grown so big, it was the size of a water balloon that was attached to a hematoma that was not going down. We had to go back into the surgery area, like originally where it was cut. I mean, and so it's all this additional surgeries and procedures that I wasn't expecting. And then for me, and how I ultimately ended up in palliative care, because that is something that still needs to be talked about, because I did think it was hospice when it was first brought up to me. I was like, oh my God, am I dying? Like, what are we talking about here? But it was after I had to have a hysterectomy and an oophorectomy, which means both ovaries out as well. Everything out, y'all. Everything out that made me, biologically a woman. And I was barely a year post cancer. I did not think that it would be a massive type of surgery. And because it was robotic, like tiny scars, yeah, it was massive. And when I came out of that surgery, all of a sudden, it's almost like a light was turned on of like pain. Because I did not go in there with all this pain, but I came out because people don't fully understand how traumatic and what trauma is caused to the body through surgeries and toxic treatments. And that's ultimately how I ended up in palliative care. But it took 3 years of me telling my doctors, hey, something's wrong with my back. Something's wrong here. Something's wrong there. And no one believed me. So what do we do, Richa, when the patient is like saying, hey, I am feeling this pain? I kept being told, oh, you're still healing from all of your cancer treatments and the side effects.
That sounds awful. And I mean, I think what's also so difficult about the situation is Sounds like you had so many different kinds of pain at once, and it was really hard to control each of those well. Like there's the post-surgical pain, which you treat so differently than can't true like cancer related pain, meaning like the somatic pain from the tumor versus just the healing and the recovery. And then also just all of this stress by itself can cause a lot of emotional and existential distress that can just exacerbate all of these other forms of pain. Um, I know you mentioned you had seen the palliative care team here. Did you visit any of the other interdisciplinary team members? Because oftentimes, I think sometimes in this situation, we really underutilize things like acupuncture or non necessarily opioid based pain regimens.
So for some people, they are able to, take an opioid or what have you, but I have to work full time. I need my head cleared. And I think it's really hard when you are someone that has to work where maybe you want to even be on disability, but you can't afford to be on disability. And so after the 3 years of fighting to say, y'all, like there's another pain going on here. And I also have chemo-induced peripheral neuropathy, and that also caused like additional pain. And then fibromyalgia, which happened after that surgery. So, like you said, it's a lot of pains flaring all at the same time, but no one was believing it. And so, once I did get into palliative care, we did try cannabis, and I didn't even realize what the procedure would be. I guess it's different by state, but like my palliative care doctor, I was impressed. Like they filled out all this paperwork for me. They're like, here, just take this to the Department of Public Health. I live in Georgia. I'm in Atlanta. And so I did that. And I have a little car carrying, for cannabis, but it didn't work. Or I should say, my expectations of thinking, oh, this is going to take my pain completely away. And I was bitterly disappointed when I realized that's not what it will do. It's going to help uh, minimize the spiciness of it and probably make you tired. And then it turned out I couldn't take it because I was like, I have to work. I have to have a clear mind. I'm a writer. Like, what are we doing? And then I did try acupuncture, but when doctors say, hey, you can try acupuncture, the bulk of the time that's not covered by insurance. Like we have to pay out of pocket for that, and we're already dealing with a lot of financial toxicity. And so now you're saying, hey, try this or that, and it's like, okay, will insurance cover that? And if I go to an acupuncturist, how many sessions are we talking about?
That's so true. And you're right. Cannabis is so different state to state. In New York, medically cannabis is legal. So it's often pretty easy for patients to see a physician that's certified in prescribing cannabis, but then going to a dispensary to help with titrations. But the part of this is oftentimes the physician's copay to certify a patient is covered, or not the copay, but the actual visit, but there's a copay with that. And then having to see a dispensary to physically even get the cannabis, it can be almost another $200 a month. And that's not really covered. There's not much agency, there's not much coverage for it. And that, like $200 is one expense that maybe some people can afford, but some people can't. And it's not just that one expense. After a while, each one of these visits, each one of these copays really adds up to much more than you would expect. So you can't really just use one copay and think, oh, it's not that big of a deal, because they just pile up.
Yeah. And it's been really hard too, because when we think of Pain Awareness Month, like, first of all, I'm glad that we're talking about this again, because it is just not talked about enough. But I often have people say, like, if you look at me right now, for those, if you're just listening, I always wear a fascinator, some hair accessory. That's my trademark in survivorship. And because I look festive, I guess, because I look, quote unquote, healthy, I often have people say, oh, well, you don't look like you're in pain. And I'm like, if I looked the way I felt, it would be Halloween 24/7. you know? And so the fact that so many of us who are in pain have to mask it, that's also an issue. And like you said, that really messes with you mentally and physically, because I do have to plan out certain like big events. Like if I go to a conference, I know it's probably going to take me a week to recover because my body is going to literally feel like it is on fire from head to toe and nothing will help. And really, all I can actually take is like maybe a muscle relaxer or something. And so, I feel like sometimes doctors aren't thinking about us holistically and what happens outside of the office to our quality of life if we have to deal with chronic pain.
And I think that's partially because a lot of the ways trainees are taught to manage pain and to assess pain is really based a lot on physical exam. So part of it is when you want to prescribe opioids in a hospital setting, you're expected as a resident or even as a fellow to go physically see the patient. And oftentimes you get such a spectrum of pain. Patients like internal pain that they're actually feeling does not correlate with what your physical assessment of what they look like in that moment is. And oftentimes there's other coping mechanisms patients use that I think get often overlooked too, right? So,
Mhm.
as a trainee, I was always taught, step outside of the room and see what the patient looks like before you walk in, like take 2 seconds to see it, and then walk in and talk to them. And the thing is, it's sometimes the patient will appear comfortably in bed watching a movie or listening to music. And then you come in and suddenly they're in even more pain. And I think oftentimes we describe this as like concerns for addiction, but when you look at the full picture, you walked in, you interrupted what their coping mechanism was to manage the pain. And it's kind of is an awful like chain. So it's you try to treat something, but when it's undertreated, it gets even worse over time because people think you're made like by giving a muscle relaxant, you think you're addressing the pain, you're taking care of all of the pain. And when the patient is telling you it's not working, I think there's a lot of blaming something on the patient, especially when they're having multi-modality pain and we're
Mhm.
using a single modal treatment regimen to address it. Whereas what we really need are different regimens that are not just opioid based, which should be a big part of it, but in like a controlled setting, obviously, so it's safe, but also like all of these. And unfortunately, for patients to have access to these resources, it's not easy.
It's not. And it is a horrible feeling when a doctor looks at you and accuses you of being a drug seeker. Like, do I look like a drug seeker? And to be talked down to, and so you're really giving, patients some insight here on like the training and, trying to read a patient's nonverbal cues, and I just know that there are sometimes where I'm like, I'm not even going to bother telling this specialist or that specialist what I'm feeling because they're not going to believe me. So what I want to know is what is the medical community, what are fellows and residents like, what are y'all doing to help shove the needle forward of first of all really seeing patients, patients who are of color, and are y'all getting that cultural competency to recognize, yeah, we're not all drug seekers, okay? And like, what are you doing to come up with other options and solutions to where we feel like we're finally being believed?
So that's a really good point, right? I think a big chunk of this too, it's so multimodal. Like usually you want a good assessment of the patient when you see a patient because you really want to know what their average moment is like in this
Mhm.
setting. And it's nice to see how a patient is right before you enter the room because you want to know what they're basically doing most of the day. But if the pain is also the thing that's limiting their functional status, that really needs to be addressed too. I think what training has been doing differently too, it's much more inclusive models on like assessing for pain, assessing for different behaviors that are associated with pain, and then also learning how to retake a history.
Mm,
So oftentimes, like that's one assessment when you walk into the room, but holding on to that belief will really color a picture. So a lot of training programs are really trying to go back and ask patients to rework their scale and re-describe their pain in different words. So one tool I learned with palliative care for a pain assessment is, I walk into a room with a patient that has told every other team member they're probably in like 20 out of 10 pain, but I saw them 30 minutes after they just got another dose of their pain medicine. So it's probably a 0 to 2 right now. And stopping at that history is not great. But what you really want to do is really sit down and just ask the patient about their pain patterns. So, how many times a day are they having pain? How often is it? What's their baseline pain? What's their worst pain? When they take a medicine, does it actually bring it down from whatever their number is to their goal number? And I think the other part too is sometimes patients and each physicians use different scales when they're describing pain. So giving people a scale
yes.
from 0 to 10 is helpful, but recognizing that my 7 is not your 7 is also really, really important because I may be living at a baseline of 0 to 1, but if a cancer patient's living at a baseline from like 4 to 5, this one episode may not be more than their baseline pain, but the one
Mhm.
that they talked about before would be significantly more. And that also will help you address your pain regimen because if it's really like a short flare, but the baseline pain is so much, you really need to think about adjusting longer acting medications as opposed to short acting medicine. And really taking a history of what the pain fluctuations is will really help tailor the medication approach better. I think the other thing too is oftentimes we're too quick to just say this is cancer related pain or this is not cancer related pain.
Yes, thank you.
And unfortunately, it's really difficult because I'm not the one that's managing every single aspect of this. But I think recognizing that even cancer patients have non-cancer related pain, but we still need to figure out a better way for this to be addressed is really, really important. And I think the other aspect that we really should work on as a group, which it also sounds like a lot of groups are turning towards, is building up better survivorship programs. And by better, I mean more like some of the programs are great. I think we just need more of them oftentimes
Right.
because a lot of the pain is so great right after cancer's supposedly cured or in remission. And it some of it does overlap with the what we traditionally think of as cancer related pain, but honestly the surgery caused some of this, the tumor did, the chemotherapy can cause neuropathy. And these are lifelong sequela patients have to be taken care of. And maybe they don't need a medical oncologist to give them more chemo, but we do need more specialists in this realm to help address these other areas.
And I have a big like issue with the pain scales, and I'm always like filling in my own, because my baseline, it's tolerable when it's a 6. It never gets below a 6. The worst is when I feel like, oh my God, I think I need to go to the emergency room. It's a 14 or 15. And so every time I say that, I've actually had some doctors say, well, we just really need you to follow the 1 to 10 method. And I'm like, that's not accurate. And so I think sometimes too, doctors, they need to check themselves because patients, for quite a few of us, we're coming in more informed, or we're advocating, or we've joined support groups and we've heard other things of questions you should ask your doctors. And then when you're presenting like ideas for them, and I can give a perfect example of when I was in palliative care, and I'd love for you, Richa, to talk a little bit more about how that can help if you are someone in pain. But my situation was a tad different because I'm not stage 4. I was stage 2A invasive lobular, but again, I had a lot of health issues, of pain and some other things, mobility, a lot of things happening all at once, and it was too much for me. And so it takes sometimes a lot of investigating and trying to figure out the right cocktail, if there even is a cocktail for you. But what really, you know, And I've actually heard other patients like experience this of that feeling of dismissiveness by their physician. Like I brought in an article about this like research that was done over in the UK, and it was in a vetted journal. And I was like, hey, can we try this? And I realized, why am I the doctor here? Why am I the one thinking outside of the box, trying to help address my pain? And they are not. So, while I was in palliative care, I made it for 2 years. And then I ultimately decided, you know what, you're not really helping me anymore. I'm just going to take control of it myself. Or the fact that I've learned to live with such high pain that if people felt what I felt on a daily basis, they'd be in the hospital.
So I mean, that's a really big issue too. I think a lot of times I wish I had the luxury of time to sit down with each of my patients and also take the time to go over like what they found. Oftentimes when patients bring me research articles, I'm sure they spent a long time looking for options for them. But also, I think what patients sometimes don't understand is a doctor's hands are also often pretty tied because they might find all of these regimens, but I may not be able to get you on that clinical trial here. I couldn't get you that medication here, or this clinical trial costs like $1 million to enroll a patient, and I can't get your insurance to cover it. Like I know that. And so it often, especially when there's so many issues that cancer patients face, and we only get 15 to 20-minute appointments to follow up with our patients, it's just not enough time. And I really wish, like, I think if we had much more time, a lot more would be addressed. And I wish there were ways to change our healthcare system to be able to allow us to give our patients that.
Me too. And I mean, quite honestly, the doctors should just say that. Like, I mean, instead of just outright dismissing it, like say, you know what? I'll bring this to another colleague, like just say something like of an acknowledgement, because then when you're not acknowledging that and saying, hey, this is systemic, I hate that I only have 20 minutes with you. And this is great, but that's out of the UK. I it's not gonna probably be in the US for like another few years. So like just saying something like that, I would have been, and I know other patients would feel at least heard and be like, okay, then you heard me. You're not outright dismissing it. Because when a doctor dismisses you consistently, and then you find another one and they do it again and again, you're going to stop sharing what you are feeling. And if the pain has increased, or if you have a new pain that's all of a sudden occurred and you don't know what that trigger was, we really need to continue working on that patient doctor relationship, even if it's only in 20 minutes, because of course that whole problem is systemic. But darn it, we got to make those minutes count and make us feel seen.
You're absolutely right. I mean, I wish there were ways to improve the system issues, right? But at some point, you just have to work with the cards you're dealt with
Right.
to get like whatever you can do. Like you just have to make the most of those that time.
And I think it's also important to ask for help. And that's been hard because I have an invisible illness now. Yeah, I'm a cancer survivor. I like to say, instead of, quote unquote, cured or remission, I like to say I'm in a relationship with no evidence of disease. Ned is my boyfriend, and we're going to be in a long-term relationship. Oh, God. But I've had to learn to tell people no sometimes, or ask for help in lifting something, or telling my friends, hey, if I end up canceling last minute, I am not being a flake. It's because I've had a pain flare up and it is so bad that I am literally I cannot move. And how like hard that is, because we want to still be invited. We want to still go out and do things. But a lot of times all that pain, especially if you're dealing with multiple types all at once, it is exhausting on top of having to do your job to pay your bills on top of all the things in, like, just cleaning, emptying a dishwasher. Like, I think sometimes people don't fully understand what pain and how much it can impede on your daily living. And it can be really hard and also really discouraging.
Very true. And I think part of it too is it's one thing to read about in a textbook. It's a different thing to be the patient that experiences it. And so listening and hearing from patient advocates and survivors like you is probably also really helpful to clinicians because it gives us a different perspective you just can't get from sitting in a library and reading a textbook.
So true. And quite honestly, that would be my dream, is to go and talk to medical school students. Because I have a million examples of things I've been through, and it's been hard. The cancer experience, no matter what type of cancer you have, like, it does change you. And as once you know, go through it, and now you do have this pain, and you try and figure out ways to describe the pain, but how also it just really, it changes you, and don't you kind of feel betrayed by your body. Like, I have felt very betrayed by my body when I have doctors telling me, oh, well, to help reduce your pain, you just need to exercise. Well, okay, when I walk and I am in pain, how do I know I'm not hurting myself further? Like, I feel like they tell us all these things, but then they don't give us the tools, or saying, here's who you should talk to, or here's the next step in getting you up and walking, you know?
That's fair. And I think part of it too is medicine is so specialized, right? Like you're giving me a really good example of a situation where I would have considered using like physical therapy for straight PM&R. A lot of like other secondary issues to figure out the etiology of pain, like radiographs to make sure there's not a fracture. But also, my knowledge is specialized in oncology and hematology because that's what I would train the most in. And so, because medicine has become so specialized, I think it's also really important to make sure we get our patients and their caregivers plugged in into a clinic that has access to so many of these multimodality like options.
Yeah, totally agree. Well, I got to tell you, I think this has been a very rich uh, conversation, and I really appreciate the insights from the medical provider perspective, and I really appreciate the willingness to listen to, a patient here.
Let's say it was so nice to listen to you too, because I honestly I feel like I hear a lot of these concerns, but it's really interesting to see how patients see these situations and opportunities for us as clinicians to improve like quality of life and care for our patients.